Good morning, everybody, and welcome to this heritage lecture by the Department of Anesthesia. I'd like to begin this session by inviting Mr. Prayojan to begin with a word of prayer.
Good morning, everyone. As we begin this workshop today, let us read a Bible verse and pray. Proverbs chapter 3, verses 5 and 6. Trust in the Lord with all your heart and lean not on your own understanding. In all your ways, acknowledge Him, and He shall direct your paths. Let us bow our heads and look to the Lord in prayer. Our Almighty God, the source of all our knowledge and understanding, we thank you and praise you, Lord, for bringing us together this morning to have this meaningful workshop, Lord. God, as we begin this workshop today, we ask your wisdom and guidance be upon all of us. God, you may enable our minds to be receptive so that, Lord, whatever that is going to be discussed, it will really enrich our community, O Lord. God, we submit our moderators, presenters, and all the attendees into your care. May grant them the eloquence of speech, the clarity of thoughts, and inspiration in them, O Lord, so that all the conversations be respectful and all the collaborations be productive and all the works will advance our society where we put witness to your name in order to bring hope and healing to the people of Master. You may guide all of us through your presence and through your spirit, O Lord. Thank you for listening to all our prayers. In Jesus' name we pray. Amen. Thank you.
Okay, so on behalf of the administrative team here in CMC, I'd like to welcome each one of you to this heritage lecture. So this is a series of lectures that have been organized to commemorate two very important events in the history of our institution. So one is 2024 marked the 100th year of work on this campus, which we call the main campus now. And this year is 125 years of our existence. And to commemorate these two very significant events in our history, we have organized these series of lectures called the Heritage Series. And Dr. Ebi, who's one of my colleagues in the directorate, coordinates this on behalf of us. So I'm very happy to see all of you here from the Department of Anesthesia and also from other departments. I wish that these quality circles and these heritage lectures would be well attended like today's is, because this is a very important lecture. It may not be something, you may not be talking about something cutting edge, but nevertheless, this is very important. I'd like to specially welcome our senior in the Department of Anesthesia, Dr. Rebecca, Dr. Grace, Dr. Nandini, Dr. Mohan, and Dr. Nagamani. Uh, it's very nostalgic events, occasions like this. It certainly takes me back to my days as a PG or even as an intern to see you all back here in person. You've been a very integral part of the institution over the years and have seen this department and been part of its growth and development over the years up until now. As an administrative team, over the last few years, you probably have seen, a lot of assetization that's happened. We've expanded into new campuses. We've brought in a lot of new technology, and we are at the cutting edge of work in many of our departments. But as an administrative team, we firmly believe that our most valuable asset is our human resources. That's all of you. And it's very important in an institution to have a group of staff who remain committed to the vision and mission of an institution. About 10 years ago, there was this book which was published called Mission Drift. And it's a fairly it's not a very large book, but it talks about various institutions that have started with a particular vision and have somewhere along the way drifted. Now, I'm proud to say that in CMC over 125 years, we haven't drifted. And one of the important reasons why there is mission drift in institutions is that the next generation doesn't know about the history of the institution. And that's why I believe sessions like this are very important. And I'm very happy to note that your department, in addition to having this lecture, has set apart the whole day for you all to interact with your seniors and to reminisce about, how God has been good to your department and for all that has happened over the years. And I would encourage other departments to do this as well. So before I hand over to the moderators for this session, I'd like to place on record on behalf of the administrative team and as a surgeon myself, our gratitude and recognition for all that you do. I know you're all often the unsung heroes of many of our surgical successes. And we probably don't say this very often, but we certainly value all that you do for us, and we want to thank you at this time. But I want to make one point today. When I walked in at 7:45 today, for once the surgeons were here before the anesthetists. So that shows that we truly value you here, and we look forward to hearing from you all. So I'll hand over now to Ekta.
Good morning, everyone. Indeed, a big day for all of us, Department of Anesthesia especially. So I think I want to begin with thanking God for his blessings to CMC so that we can walk today on 125th year of hospital campus, and also Department Directorate Office for having this opportunity for us to talk about our department, the journey of department. I'm very aware that we have only 1 hour. So time is the crux. Otherwise, we would have taken whole day and taken you through the journey of anesthesia. Responding to Dr. Ranjan, we were there at 7 a.m. here, and we have completed our breakfast, by the way. So I will not waste time because time is money here. I will hand over to Dr. Tony, who is going to introduce all of our speakers for the day. Okay, over to you.
Good morning to everyone, and those present here and those viewing online. We're grateful to the Lord Jesus Christ and the administration for the opportunity to partake in the heritage lectures of the Christian Medical College Vellore's 125th year. Respected friends and colleagues from the various departments of CMC, it is the privilege of the Department of Anesthesia to introduce to you some of the luminaries of CMC anesthesia for the heritage lecture. We have 3 of our eminent teachers and mentors who will be the speakers this morning. Our first speaker this morning is Professor Dr. Nandini Korula. Dr. Nandini belongs to the CMC postgraduate alumnus of 1970 and was an integral part of the department till 2007. An extraordinary clinical anesthetist and teacher, she is the pioneer who started the surgical intensive care unit. Please welcome Professor Dr. Nandini Korula for the lecture.
So I will begin my lecture this morning by taking a close look at the meaning of the word heritage. I know we all know what it means, but still. Let us see, UNESCO has already defined it as the legacy of the past, what we live with today, and what we pass on to future generations. Kya ho gaya? Thank you. That makes it less confusing. You know where to look. Okay. Now, I've also added on this heritage tree here. It's a significant tree, one that is large and irreplaceable. This tree is symbolic of our heritage. The roots of the tree symbolize the past, the foundation on which the entire structure is supported. The trunk represents the present, that is a bridge between the past and the future. Now, this tree is constantly evolving, being shaped, reshaped, adapting, growing in the midst of complex societal changes, globalization, and technological advances. Our heritage defines us. The present stretches into the future, never losing touch with its past, its unique identity. Now let us take a journey into our heritage. Founded in 1979, the department is just over 75 years old today. Now, much of the information I'm presenting today is gleaned from the souvenir released at the Anesthesia Department reunion in 1990. This reunion was uniquely attended not just by Gwenda Lewis and others who had worked and trained in the department, but also by other eminent anesthetists who had visited Vellore in the early years. The memoirs in the souvenir made extremely interesting reading, giving me a glimpse into the past, the years between 1949 and 1969. Thereafter, this narrative is based on my personal perspective, ending with Dr. Valerie Major's era. For lack of information and constraints of time, if I have omitted some names and their contributions to the shaping of our department, I beg pardon. Gwenda Lewis arrived in Vellore in response to an ad in the British Medical Journal in 1945. The ad was for an anesthetist in the Christian Medical College, Vellore, South India. She had heard nothing about this. She knew nothing about this place. She wrote to the Baptist Missionary Society in Britain asking about Vellore, and after a series of interviews, she was accepted and sent to the Missionary Training College in preparation for the assignment of a representative of the Baptist Church in Britain to CMC Vellore. She started the department in 1949 with a motley group of young, enthusiastic helpers, some of whom were medical students who later joined the department. Before Dr. Lewis's arrival, Dr. Ida Scudder had used chloroform anesthesia for her patients with the help of her cook's wife, who she had trained. Now, figures given for the number of anesthetics given by her in the year 1947 to 48 was 1,326 chloroform, mind you. In 1953, Dr. Lewis contracted polio, possibly from mouth-to-mouth resuscitation of a child with polio. After several months of recovery and rehabilitation overseas, Dr. Lewis returned to Vellore. Undaunted by the blow fate had dealt her, she resumed work, refusing to allow her disabilities to hamper in any way her enthusiasm and dedication to work. She later wrote about this chapter in her life, in the words quoted on the slide. Many eminent anesthetists in the early years of the department came from various parts of the world to experience firsthand the incredible work that was being done in Vellore at the time and to help in whatever way they could. Some of these names are iconic, and I'm sure any student of anesthesia would recognize them. You can see Lee, Alfred Lee. His book is our Bible, or was our Bible, mine anyway. Then you have McIntosh, Mushin, and Dundee. The budding department benefited greatly from their visits, needless to say. Initially, Dr. Lewis was the sole anesthetist with medical students, as I have said before, and later house surgeons and anesthetists from overseas and other hospitals in India spent varying periods of time in the department. Somewhere in the early 50s, I did not find much information about this. Dr. Kinshi joined the department. Now, the Kinshi era has been described as a colorful one. Kinshi apparently was this maverick anesthetist who could devise ingenious ways of tackling the most complex surgical challenges with the most primitive equipment at hand. Dr. Varghese and Sundaram, who were house surgeons in the department at the time, have both paid tribute to this man in their memoirs. He left in 1960. Dr. Dalton came as a replacement for Dr. Lewis when she went on furlough for a year in 1957. But she stayed on. She stayed on until 1962. Now, a very important thing happened. In 1952, Dr. Lewis appointed and trained 17-year-old Sammy as we knew him, as an anesthesia technician. Soon afterwards, Davidson joined, and she writes that these technicians were possibly the very first anesthesia technicians in the world. Reliable and quick to pick up on her needs, they proved to be of invaluable help to her. Both Sammy and David remained in the department till they retired. Then two others joined, Joseph and Raja, bringing the number up to 4. Now, 1958 to 59, 3 staff positions were recognized by the Madras University. And finally, DA and MD courses were started. And soon we had PGs in the department. Okay. Just a picture of the department taken in the mid-50s. We can see Dr. Gwenda Lewis there. That is Dr. Kinshi. This was another doctor who was there at the time, but there's not much known about him, Biren Bhattacharya. This is David, our technician, Dr. Sundaram, whom I will be talking about later, Sammy, Dr. Varki, who of course we know, and this was Raja. Now, what was it like in the 40s and 50s? I really wouldn't know, but going back through the memoirs, ether was the only anesthetic agent available. Ethyl chloride sprayed on a Schimmelbusch mask. I don't know whether you've heard about it. It's a wire mask, and there are just the right number of gauze pieces there so that it retains the vapor of the ether and yet does not drop as drops on the patient's face, making him or her uncomfortable. So ether sprayed on a Schimmelbusch mask first for quick induction, followed by open drop ether on a spontaneously breathing patient. They obviously could control the depth of anesthesia by themselves, the patients. Now, what was the monitoring like? Very, very, very basic. The finger on the pulse, and when the pulse was out of reach, either a stethoscope taped to the chest or an esophageal stethoscope later that came in. Blood pressure monitoring with the sphygmomanometer, observing chest movements and type of breathing. That was very important, which gave the depth of anesthesia that the patient was reaching, and color of the blood in the surgical field. And that was all. Now, giving safe and adequate anesthesia was more of an art than a science in those days. Should I say that? Yeah, okay. Now, you see here, most likely, this is what it looked like when it first started. And the first 2 operating rooms were built in 1930s, with a single surgeon alternately using the tables. Soon this changed to a simultaneous use of both tables. General surgery, obs-gynae, and ortho procedures formed the bulk of the work. In and by 1950, 2 theaters dedicated to cardiothoracic and neurosurgery were added. And just 1 year later, the number of anesthetics administered totaled 2,785. 5 years later, numbers had doubled. And another 5 years almost reached 7,000. Anyway, by the mid-60s, 2 more theaters brought up the total number of theaters to 6, along with a 7th septic theater. The growth of the theaters was topsy-turvy, dictated more by the needs of the day than by any plan. This old theater block functioned where the present radiology extension is located, next to the chapel. With the start of cardiothoracic and neurosurgery, anesthetic techniques evolved rapidly. You can see that the ether era was rapidly coming to a close. You see the Boyle's machine with all its basic components compressed gases, simple vaporizers for ether, trilene and halothane, soda canisters, and most importantly, the drugs. Thiopentone, muscle relaxants, namely succinylcholine, which I believe is still prevalent, flaxidil and curare, circuits, closed circuits and Magel circuits, and regional anesthesia, spinal anesthesia, the two tunicae Beers block. I don't know how much is used, how much it's very, very useful. Brachial plexus block became very popular. Now, major surgical cases, neurosurgical cases were done on trilene and spontaneous breathing using Magel circuit. Relaxants and controlled ventilation came into the picture as cardiothoracic surgery started. Dr. Mansfield used blockers for lung resections, introducing one lung anesthesia. And the Blease ventilator was the only ventilator in the department and was kept reserved for open heart surgery. Now, I'd like to say a few words about Dr. Sundaram and Dr. Ruth Mansfield. Dr. Sundaram had spent several years in Vellore working as a house surgeon alongside Dr. Gwendis, Dr. Kinsey, and Dr. Delton. He was a neuroanesthetist who was based in Mass General Hospital, Boston, but he was a very frequent visitor to our department. Since his mother was in Chennai, he used to come almost every year, spending weeks sharing his skills and knowledge with us. And Dr. Mansfield was one other such friend, an eminent cardiothoracic anesthetist from Brompton, awarded the OBE in her country for meritorious service. She spent many months in our department after her retirement. And old-timers in the department, just a few, would surely remember both these individuals who contributed a deal not just to anesthesia, but also to the cardiothoracic and neurosurgical departments, extending their benefits of their experience in post-operative care, ICU care. Dr. Varki. Dr. Varki had been associated with the department in Dr. Gwenda Lewis's time from his medical student days. He joined the department in 1952 as a house surgeon and learned the art of giving anesthesia from the likes of Lewis and Kinsey. He was sent to Canada in 1957 for gaining formal training in neuroanesthesia, returned to Vellore in 1962 with his fellowship in anesthesia. He was assiduously groomed to take over headship of the department by Dr. Gwenda Lewis. And he did so in 1960, I think it was either immediately after she left or a little later in 1969. Dr. Varki was a wonderful human being. His work ethics, his kind and generous nature endeared him. I have to talk about Dr. Varki a bit, so spare me a little time here. So his work ethics, his kind and generous nature endeared him to everyone in the theaters, be it surgeon, anesthetist, technician, nurse, or attender. He would not think twice about transferring patients from trolley to table or back, wheeling trolleys up and down theaters, doubling up as a surgical assistant whenever he saw the need, all done unobtrusively without fanfare. He was respected and greatly trusted by the surgeons who accepted his decisions on patients without question. I joined the department. Where the hell is that? Next one now. For 3 months of my house surgeons in 1969. Since I had already finished 3 months in neurosurgery, I was posted regularly in the neuro theater. Long hours with an esophageal stethoscope plugged in my ears, listening for telltale signs of air embolism, eyes watching the movements of the bag to warn the surgeon of any encroachment of the brainstem. Once I watched with horror. The bag had stopped moving. Panic-stricken, I could barely hear Dr. Varki coolly informing Dr. Chandy that his patient had stopped breathing, but the suction bottle had started breathing. These should have been nightmare days, but mostly they were a surrealistic haze. I could not have been more overawed and asked for a better mentor. Later, as a DA student, I was given neuro lists as a senior with just my 3 months house surgery experience. The confidence and trust that Dr. Varki placed in his students, giving them such enormous responsibility, all the while keeping half an eye on them, ensuring at all times that they never got into any serious trouble, went a long way into making us good anesthetists, even if I say so myself. Often reward resuscitation calls would have us running to the wards with laryngoscope, tube, ambo bag, and some instances we remain bagging the patient till the bird ventilator, right? But we could be sure of hot coffee and samosas waiting to resuscitate us on our return. He gave us PGs a sense of pride in our work. Working round the clock, almost never seeing the light of day, we PGs were a happy lot. And that was Dr. Varki and his special magic. After finishing our long list, we would still not be unhappy about going to wards for pre-op assessment of patients, often having to wake up patients in deep slumber. Looking back, I can honestly, in all honesty, say that those days in Dr. Varki's department were the golden years of my entire PG or staff days. Dr. Varki resigned from the department I should have brought this slide on earlier. I apologize. In 1971. Now, Dr. Martin Isaac takes over from Dr. Varki, 1971 or around there. Dr. Martin Isaac, like Dr. Varki, had also been closely associated with the department since Dr. Gwenda Lewis's time. He was the first DA student, 1958. He left to do his MD in Delhi and later to do his doctorate in Belfast, returning to join as staff in 1971. He became the head when Dr. Varki left. In 1971, soon after he joined, he organized the theater setup for the first renal transplant in CMC. He was one of the architects of the new theater complex, 14 theaters, which still exists, 14 theaters with induction rooms between, complete with recovery room, coffee lounge, etc., etc., etc. This was the first time in the history of our department that anesthetists could claim to have their own offices, conference room, outside of the theaters. We moved from the theaters, old theaters, to the new in 1975. Dr. Isaac resigned in 1976, and Dr. Valerie Major took over as next head of department. Dr. Major had been in the department for several years before becoming head. She, along with Dr. Varki, were my role models and were wholly responsible for my decision to take up anesthesia. Dr. Major had always been a teacher and an anesthetist par excellence. Her lectures on basics in anesthesia were mesmerizing. What she taught, the way she taught what she taught, remained firmly ingrained in her students long after they've left the department and gone on to become eminent teachers and anesthetists themselves, not just in the country, but worldwide. She was a role model for almost all of her trainees, and this was evident in the many tributes paid to her at the memorial held for her by the department on 24th June 2023, soon after she passed in Cardiff. On this very same day, the skill lab existing in the department today was dedicated in her name. She's not one to extol her own achievements, and few knew of the PASC award that she had received in Britain for her meritorious service in Vellore. Passionate about her work, she took meticulous care, whatever be the case. Safety was her first and last motto. I remember her saying that apparently simple cases like D's and C's needed more anesthetic skill than more sophisticated cases. And I think many of us have realized that. She stood by firm principles of hard work, honesty, and integrity, did not tolerate shoddy work or slackness, yet was always kind and understanding when distress was genuine. Her unstinting support of staff and trainees in the face of mitigating circumstances often led her into conflict with surgeons. But if Dr. Major was at the head of the table, surgeons rested easy in their work. Her focus on clinical work and training left her no time for any research. And the publications of papers in journals in her time were few and far between. Gifted with a fine sense of humor, she was quick to see the lighter side of things. And if she was quick to flare up or get angry, it was because of her instinctive impatience for mediocrity, inefficiency, or anything not precise on the part of anyone in the theater. Many diverse people, not just from the department, have gone to her with personal problems. She was always approachable, offering good counsel with a great deal of insight into their problems. During her time as HOD, the department grew in the number of PGs, staff, and technicians. Departmental services were extended to Shell Hospital, MHC, Chad Hospital, Mission Hospitals. The department saw the establishment of formal technician training courses, the introduction of scavenging systems, improvements in the recovery room, and the establishment of a 12-bedded ICU, surgical ICU, adjacent to the recovery room. Dr. Valerie Major retired in May 1995, leaving behind her a rich legacy of a department known all over our country for its high standards of anesthetic care and its excellence in training wannabe anesthetists. Just a picture of the department in the 80s. I don't know whether I just leave it because it's take too long. And this is a long list in and around 1990, gives us some idea of the increase in the number of staff that the department had. Now, CMC Vellore has many firsts to its credit. The first complex surgical challenge of excision of a pheochromocytoma in 1959 had Dr. Kinshi at the head of the table using the Magel circuit and ether, no relaxants. VSD closure on the heart-lung bypass with disc oxygenators in 1961 was the start of the open heart surgery era in Vellore. And the first craniotomy for a frontal lobe tumor also happened in the same year. The next first was a renal transplant in 1971. Surgical achievements owe much to anesthesia. The two are intertwined, and as surgical specialties evolve, becoming more and more complex, so do techniques of anesthesia and monitoring. Anesthetists' involvement with patients does not end with surgery. Dr. Ruth Mansfield set us the earliest example with her early morning and late night rounds in the KN-ICU, which was the cardiothoracic ICU then. Later, with the inception of the surgical ICU by the anesthesia department, post-operative intensive care came to be looked after primarily, I think, by anesthetists. And today, although the surgical ICU is a part of the super specialty of critical care medicine, it continues to be in the care of anesthetists, branching out as intensivists. The formidable reputation this department gained in Dr. Major's era is thus being added on to the already rich heritage that was inherited from others before her time. We have become the past, and you, the present, will do so too in time. And the cycle will continue. The cyclical interconnectedness. We are dynamic co-creators. Heritage shapes us, but we also shape it. I end now with this poem by Longfellow. Thank you.
Thank you, ma'am, for those insightful words. Our next eminent speaker is Professor Dr. Rebecca Jacob. Dr. Rebecca belongs to the CMC postgraduate alumnus of 1973. She retired as Professor of Anesthesia in 2008, having held the position of the head of the department. She has had many feathers in her cap. She is the pioneer to make pediatric anesthesia a specialty at CMC. She is the president of the Asian Society of Pediatric Anesthesia, the Indian Association of Pediatric Anesthesia, and the chief editor of the very popular book, Understanding Pediatric Anesthesia. Please welcome Dr. Rebecca Jacob.
Thank you, Tony. When I was preparing this talk, I was reading a book on the life of Jamshedji Tata. And this quote struck me. Let us reminisce about our times, but do not make judgments about our modern day successors. They are managing a vastly different business in a vastly different world. So, hats off to you who are doing it now, but I would like to continue with the reminiscing. We've heard that the Department of Anesthesia was well known for our service, for our education, and for safety. In 1995, May, Dr. Valerie Major retired and Dr. Saro Devanandan took over. She was a feisty lady and she had certain things she believed in and she followed it through. So let's look at a couple of things that Saro had done. Now, till that, in the early days, you saw the old theater. At the end of surgery, would you believe that tonsillectomies would take 15 to 18 minutes? In Dr. Desmond's hands, that's what it was. We would extubate the patient, flip the patient on its side, and remember, we extubated them deep because we had only ether, and we take the patient to the ward. Very often, it would be us 2 weeks into anesthesia, put on a blue house coat and run with the patient down to I ward. We inform the nurse, we brought you a patient, and that's about it, and run back to do the next case. We had no recovery areas. But the concept of a recovery room came from Saro Devanandan. She even managed to get an old anesthesia machine to be kept in the recovery room, and she trained the first recovery nurse, Glory. I wonder whether any of you remember Glory. Now, because of her, we have trained personnel staffing our recovery rooms. We have monitoring, we have oxygen, suction, and means of resuscitation. The other thing we used to have was patients with trismus or maxillofacial injuries, and we all had to do blind nasal intubations. There were some of us who were good, like Dr. Manikam. Others of us would see this on our list and shudder to, oh no, do I have to do a blind nasal? But Saru came back from the States and she insisted that we bought the first fiber optic scope. So thank you, Saru, for beginning the modernization. In 1995, December, Saru retired and I took over the department. And here we ushered in an era of cutting edge technology, along with education and safety. We still insisted on a hand on the pulse. We still said, look at the field, see what the surgeon is doing, don't let them get away with a lot. And we also had our stethoscopes, but we got pulse oximeters and multi-channel monitors, not in 1 or 2 theaters, but in every theater. We went into IV cannulae, not the old hypodermic needles with which we were struggling till then. We didn't have any more metal 3-way taps. We had multi-port 3-way taps and 3-way taps with extensions. No more glass bottles of blood with rubber tubing. No more counting drops to tell what the volume of fluid was that we were giving. We had infusion pumps. We had burette sets, and babies were getting accurate fluids. But the intensivists wanted lots and lots of lines. Well, they got it. Warming babies was using a sheet over the top of a overhead light, but then we got hot air warmers. And this is from your pictures. We didn't have to hand ventilate our babies anymore. We had fancy workstations, and we didn't have to ventilate our babies overnight. We've sat through the whole night ventilating babies after we did PDA ligations. But now we had ventilators. The MRI machine came, and we were told that we would have to anesthetize patients there. And I said, no, we're not going to anesthetize patients there unless you give us an MRI compatible anesthetic machine. You get me an anesthetic machine and I will anesthetize patients there. So they did get it to us, and we were the first in India to get an MRI compatible anesthetic machine. Ultrasonography came in to stay. Initially, we used to borrow the ultrasound machine from obstetric gynecology, but then we got our own. Now, operating rooms before 1975, you saw Nandini's pictures, where the old OT is located near the chapel. We had 7 OTs in all, 4 on the ground floor and 3 on the first floor. It was connected by an internal staircase, And if there was an emergency, you had to run up those stairs and get to the floor above. On the ground floor, we had only 2 air-conditioned theaters, neuro and cardiac. Renal transplants were done at night because we needed both air-conditioned theaters. The other 2 were large. You saw the picture on Nandini's slides. And they had ventilators and fans and doors. Can you imagine that now? Well, in 1975, we opened these theaters, which were 14 fully air-conditioned operating theaters with anesthesia rooms between theaters and a recovery area. In 2001, we got the women and children section, and no longer did we have to grab children at the control desk, carry them yelling and screaming into theater. We explained to our patients, relatives, and to the patients themselves, the older children. And then anesthesia for those children became a fun time, a fun place for them to visit. It was great that they could go to sleep in their father's arms. They could wake up in their mother's arms. How many of you have children who you would like treated well? Well, pediatric anesthesia came into its own. Anesthesia technicians, we heard about from Nandini. We had Samuel, Davidson, Raja, and Joseph. And it was felt they were enough at the beginning, but not for 14 operation theaters. And so when we met, they requested we get more technicians into a training program. And Dr. Major asked me to set up their training program. So in 1991, we selected 4 students, and I set up a syllabus. The doctors did some of the teaching, but the practical teaching was done by others, the 4 you heard of earlier. On the left, you see the first batch, and on the right, you see the second batch, and you recognize some of the people there. Now, the progress of technician training, the diploma was in 1992, a BSc started in 2012, the CMAI course in 2017. The intake for the diploma was 15 per year. Intake for BSc rose to 7 per year. Now, that was in 2023, there are 109 technicians from that set of 4. Another group we had were the instrument technicians. We had so much more equipment coming into the department. We needed people to help us maintain them. Initially, we had only Ravi Shankar, then Nandakumar joined him. And they not only maintained our equipment, but very often taught us how to use them properly, how to clean them and maintain them properly. And I'm sure all the anesthetists here will agree with me that we cannot do without our instrument technicians. Now, till that time, pre-anesthetic consultations used to be handled by consultants receiving a consultation slip. But seeing patients as outpatients started in the late 1990s. Usually these were held in the surgical outpatients in the afternoons and were often staffed by senior consultants, a junior consultant, and postgrads. Poor Dr. Mamie Zachariah, who was posted there most of the time, and she was the senior consultant there. CPR classes for other departments we held in the basement on Wednesday afternoons. Pain clinics were held every Friday in the PMR departments in collaboration with PMR, psychiatry, and pharmacology. The World Federation Societies of Anesthetists decided to recognize the Christian Medical College Anesthesia Department for its Pediatric Anesthesia Training Fellowship, and this was only the second in the world after Chile. We trained a number of them from Asia. We also have trained people from Africa and parts of Papua New Guinea. In the year 2004, I realized that a lot of people across India were afraid to anesthetize small babies. And we needed a simple textbook to go on. So in 2006, I brought out this book. Now, it may have been my brainchild. It still has my name on the cover, but I could not have done it without the team from the Department of Anesthesia, CMC. We've started in 2006, 17 years later, the team still continues. Those who started as postgraduates are now senior consultants all over the world, but they still hold CMC very close to their hearts. Now we were encouraged to attend conferences and present papers, publish as well. Initially, Geeta Nath, Meena Cherian, and I went to the World Congress in 1996 in Sydney, Australia. Grace, Burgess Cherian, and I attended the SACA meeting in Colombo. Final-year MDs were encouraged to present their theses at all the annual Indian anesthesiology conferences, such as in Hyderabad, Delhi. Some of them went to Kathmandu as well. Postgraduates presented papers at regional conferences. In fact, it was Sargent's batch of 60 MD students who were the first group to represent CMC anesthesia department at RACE in Chennai. And they presented blood banking, and they were superb. Dr. Grace Korula won laurels for the department in neuroanesthesia. I concentrated on cardiovascular and thoracic anesthesia and pediatrics. Now, we also had workshops, annual meetings, and international meetings. The SACA meeting, which was held in 1999 in Chennai, Grace and I looked after the scientific deliberations, but this book, the CME Scientific Proceedings, was printed and put together by a team here in this department, led by Chair Susan Jacob. They worked night and day, and they brought out this beautiful book. We held an airway workshop. I think it was Anne's group who were seniors at that time. Annual trips, we all went to Chennai, to the oxygen plant to see how oxygen was manufactured. The Asian Society of Pediatric Anesthesia we had in 2006, where we ran 12 parallel workshops. People like Venkatesan, Tony, Cherian, they were people who led groups for these workshops. But what was remarkable about these workshops? We had a number of famous foreign faculty who came to run these workshops. And I contacted them and said, when our people run workshops, they do not get time to attend the workshops, nor do they get to handle this fancy equipment. And all those foreign faculty stayed late into the night, well beyond midnight, to train our people to handle equipment. And the companies also stayed back. So everyone could handle fiber optic scopes and laryngoscopes and so on. So people do care. But Saturdays, as you know, are sacrosanct. Weekdays, we all worked very hard. We had long hours of work. But on Saturdays, the surgeons had to prove to me that their cases were really emergencies. Otherwise, they did not get done in the mornings. So it was our day to see the sun. We started off the day with staff meetings. We had prayers with lots of enjoyable, joyous singing. Anybody who played a guitar was very welcome. And then we all ran upstairs for coffee and snacks. And we greeted the man from the YWCA canteen like long lost brother because we were hungry. And then we came back to our classes, lectures, discussions, and journal clubs. We also had time to enjoy each other's company. We climbed College Hill, played silly games, and then ate big bungalow food. How many of us can forget our biryani, fish pie, moussaka, tender coconut pudding, and caramel custard? Now, many years ago, when I was head of this department, I was asked by the then director, Dr. V.I. Martin, CMC is famous for neurosurgery in the 50s, cardiac surgery in the 60s, renal transplantation in the 70s, hematology, liver transplant, etc., etc. What have you done? My reply, none of the above would have been possible without anesthesia. Thank you.
Thank you, ma'am. Our next eminent luminary is Professor Dr. Grace Korula. Dr. Grace belongs to the batch of 1978 of post-graduation at CMC Vellore. She retired as Professor of Anesthesia in 2012, having also held the position of the head of the department here at CMC. She was one of the pioneers of neuroanesthesia in India and instrumental in developing neuroanesthesia as a subspecialty. She became president of the Indian Society of Neuroanesthesia and Critical Care in 2008 and was awarded the Eminent Teacher Award by the Society in 2020. Please welcome Dr. Grace Korula.
Thank you, Tony. Good morning, everyone. Let me start by telling you how I saw the activities of the anesthesia department over the different phases of my career and beyond, in the light of the vision of Dr. Ida Scudder, excellence in service, excellence in education, and excellence in research, all in the spirit of Christ. This is also an introspection. Periodic introspection will help us to know ourselves a little bit better. Perhaps there is scope for improvement. The year was 1978. We were a small team back then. 3 professors, 2 MDs, 3 diplomas per year, and a few non-PGs. The 3 professors, Dr. Major, Dr. Sarodevananthan, and Dr. Prabhakar, had totally different personalities. I would have liked to expand on that, but due to lack of time, I'll refrain from it. Dr. Nandini joined later with her vivaciousness. Together, they taught us not only the subject and the skills needed, but values, a sense of responsibility, discipline, the importance of documentation, friendliness, and lightheartedness. My seniors and colleagues and the senior technicians too were very understanding and went out of their way to make life easier in these early days. You saw what happens on Saturday mornings. All these made the atmosphere for training inspirational, intense, yet relaxing. In fact, the best I can say. If we overworked, I didn't notice it. For me, as a PG student, there was excellence in education and in the service that I received from the department. But this is one stage in life. Like a small child, we are happy when we get what we want. We don't really know the complexities of being part of a large organization. When I joined as a consultant, there were 7 of us. We lost Nandini, the surgical ICU. Our loss was their gain. Later on, Dr. Nagamani joined her, and now we could sleep in peace after entrusting our sick patients to them. Working in the department continued to be enjoyable with good friends like Dr. Mohan, Dr. Mimi, Dr. Manikam, and there was a sense of belonging. This was a time when we fine-tuned our skills and became more competent as anesthesiologists. Anesthesia is one department where every day you interact not only with patients, but another formidable group. Any guesses? The surgeons. These interactions made us go through various emotions: admiration, amusement, anger, anxiety, boredom, terror, and relief when finally the surgery is over. With seniority comes responsibility. We had to make decisions. The decision involved not only us, but the patients, surgeons, and the institution. One such major decision was to cancel or not to cancel a case. If we cancel a case, the the patient suffers. If we accept the case, the juniors, including me, can go home only late. What about the families? This was a major dilemma. The department had set time after which the last case of the day would not be taken up. It was 2:30 p.m. if it was a major operation, and in the case of minor operation, 4 p.m., as the hospital working hours were 8 to 4:30 p.m. Some of the surgeons, the smart ones, would post their longest case, which could take about 6 hours, hoping it would be taken up before 2:30. But you know, in reality, doesn't always happen. So we canceled some of these cases, and we felt we were right. But now looking back, canceling some of these, I was probably more right than being excellent in service to the patient in the spirit of Christ. I wonder what Christ would have said. Much later, when Dr. Sarah Nainen was the HOD, the department tried to address the problem by bringing a shift system. She also convinced the administration to shift the pre-anesthetic clinic to nearer the OR, and it now functions full day as against a half-day clinic. I think nowadays more anesthetists see the daylight hours. Dr. Rebecca has told us of the development that took place in the department. Her untiring efforts and perseverance in accomplishing anything she set out to do is worth emulating. I will try to pick up from Dr. Rebecca left off as far as the further developments in the department is concerned. I remember speaking to I think it was at the surgeons meeting in 2007, the 60th year of our existence. The department had grown significantly. The number of operations had gone up from 9,000 when I was a PG to around 31,200, covering 32 areas. Our technicians, under the leadership of James, Bharat, and the instrument technicians, rose to the challenge every time there was a change. The total number of MD students we trained in CMC was 160 at that time. Many of our postgraduates and consultants are occupying prominent positions in their field in India and abroad, doing excellent work, and we are very proud of them. A few are doing long mission work. Dr. Lata in Notanchatram, Dr. Anne, who now looks after the missions office in CMC, deserve special mention. The surgical subspecialties were growing steadily. However, there was no real specialization in the department and no combined team management of patients by surgeons and anesthesiologists on a regular basis, except for a fixed list for some senior consultants once a week in some specialties. Since the broad surgical and super specialties departments in CMC were doing complex and difficult surgeries, those of us who worked closely with them felt the need to team up with them on a more permanent basis in improving the services, not only for better patient outcomes, but also for better training of junior staff and trainees, for research and development of the specialty. With this in mind, the department was divided into 5 units in 2011. Unit 1 worked with general surgery, Unit 2 with orthopedics and plastic surgery, Unit 3 with neurosurgery and neurology, 4 with cardiac and ENT, and Unit 5 with OG and pediatrics. Some of the peripheral services were shared by 5 units. These units are trying to follow the legacy of Dr. Lewis and Dr. Major to this day. I remember the time when Dr. Tony went to do fellowship for liver transplantation anesthesia in Canada. I used to get complimentary emails from the department in Toronto and also asking if he had others of his caliber who could replace Tony when he finished his training. He and Dr. Chitra have developed a good team in Unit 1 doing commendable work. I've also heard from the orthopedics team how their post-op patients are being mobilized much earlier these days with the various ultrasound-guided nerve blocks, that the recovery of patients have become much smoother. Unit 2 has made this possible. Thank you, Sergeant, Serena, Rahul, and their team for this excellence in service, not only in the operating room, but extending into the post-operative period. Post-op pain relief is not only for the orthopedics patients in CMC, but all patients who need pain relief after surgery. Dr. Mary Korula was passionate about this, and the acute pain service she started has become a huge success. This team of anesthetists and nurses are available 24 hours. Ekta and Anita both did fellowship abroad in pediatrics anesthesia and are maintaining a high standard of care. You have already heard from Dr. Rebecca about the fellowship program they are conducting successfully. Having separate departments was a mandatory requirement of the Medical Council of India to start a DM degree course. So we were handicapped in this as we remained as one unit. Though CMC had no DM course in neuroanesthesia, when AIMS New Delhi started theirs, they sent their DM students in rotation to our department for training. We had a fellowship program in neuroanesthesia. We knew it would be just a question of time before we could start DM programs. And Dr. Georgine went to Sri Jitra Institute to acquire a DM degree in neuroanesthesia using her study leave, incurring personal sacrifice and thus prepared for a time when the course could begin. It took almost a decade for this to happen. And in 2019, neuroanesthesia became a separate department with Georgine as the head. And in 2020, MCI sanctioned DM. CMC was the first institution to be sanctioned DM course in neuroanesthesia under the MCI NMC. Dr. Ramamani by then had done a 3-year fellowship in neuroanesthesia in Toronto and had become professor in the department. But she underwent the course in CMC and passed out as the first candidate to pursue the DM course in CMC. By this time, Dr. Karen also did DM and has joined the team, and they're doing excellent service. I'm happy to hear that cardiac anesthesia has also become a separate specialty, and hopefully we'll be able to start the DM course soon. Dr. Raj and Dr. Satish had built up the specialty of cardiac anesthesia and trained several fellowship students. Dr. Balaji and Dr. Krupakaran had completed their FNB in cardiac anesthesia, and Dr. Balaji is currently heading the department. Dr. Ilangovan, Dr. Sudha, and Dr. Varsha have joined the department after completing their DM. It is a matter of joy and pleasure for me to see the younger generation excel in their areas of service. But one thing saddens me is to hear that anesthesia and some specialties do not have adequate middle-level staff. They are the ones who can contribute most to the excellence of an institution. However many super specialties or subspecialties are started, basic anesthesia will still remain the foundation of the specialty of anesthesia. Training and empowering 100 students at one time is a big challenge and responsibility. I assume they are also being trained to manage with less sophisticated equipment and monitors, which are available in rural hospitals, and also taught to give cost-effective services. This will be excellence of service we can do for our country. Coming to research, in the early years, the pioneers were trying to cope with the clinical demands. Many of the thesis work done was good studies, but no emphasis was on publishing these studies, till publication of articles became mandatory for promotion. We have a good number of relevant studies done and papers published over the years. I was looking at the annual report. I was happy to see that collaborative studies with other departments and with other institutions, and also with ICMR funded projects are also in progress, and that they are working towards excellence. I believe every major decision that we make as department or as an institution is done in good faith after much deliberation. We all like to say we are trained in CMC because of its reputation for excellence. For excellence to continue, new ideas and changes in our small setups are necessary. They may look like a small drop in the ocean, but they add up. In conclusion, I want to say there comes a time in life when one wakes up in the morning looking forward to the day, knowing this is what I want to do with my life. I would call it the stage of fulfillment. Some may say awareness of your calling. I cannot think of any better place than CMC to accomplish this. I wish each one of you fulfillment in what you do. Thank you.
Dr. Hema is the first MD from anesthesia. She had sent recollections of the department, but because time is well past, I will not be talking much about her. That's Dr. Hema is the one in the yellow sari on the extreme left. And she sent pictures of what she used in those days as anesthetics. And well, some things never change, doesn't it? Time is insufficient to mention all the doyens of anesthesia and their many contributions to the department. And some of them are present here with us this morning. We acknowledge with gratefulness all your valuable contributions and the way our department was shaped for the future generations. I now invite Dr. Ekta, the current head of the department, to give the final talk of the heritage lecture.
Good morning, everyone. I think I'm overwhelmed and so much I heard, and it's indeed a pleasure and honor to be sitting here and listening to what the doins of anesthesia and our mentor and teachers have told us. My job in next 3 minutes, I'll try to keep it to 3 minutes, though last night I practiced and it is not less than 6 minutes. I'll try my best. My job here is to give the glimpse of the department, what the current department is, and I'm doing it on behalf of each and every member of the department. I have purposefully put this picture to say that we probably are one of the very few clinical departments who are covering all the 4 campuses of the institution. The main campus, the Ranipet campus, the Shell Hospital, and psychiatry department for the ECT. Not easy, but it's happening. This is very interesting picture, 24 June 2023, when the past, the present, and the future came together to celebrate a big day, to celebrate the life of Dr. Valerie Major together. And I think we all, one way or the other, she has inspired us directly or indirectly. This is the disclaimer. If we have seen further than others, it is by standing up on the shoulders of the giants. You have heard from visionaries, their mentors, and I would like to say they are the visionaries for our department. And there's a reason why I have put that picture in the corner, this one, to say that it is almost impossible to take each and everybody's name, but this ray of light actually is each and everybody in the department who entered department for long period or short period, but has left an impact and has molded us as a department. I have to tell you, as Dr. Grace already mentioned, why 2011 the units came and the idea was specialization. We are following pretty much the same principle, ma'am. And 2024, we actually proposed the 6th unit, which is on the way. And this is trauma to make sure the development of trauma unit happens. During this time, in last couple of years, Department of Anesthesia gave birth to 2 departments, Department of Neuroanesthesia and Department of Cardiac Anesthesia. And we are hoping to have one more delivery. Who we are. We seek to be a witness to the healing ministry of Christ through excellence in education, service, and research. So I'll take you ESR one by one. So education, we very much follow the same traditional way of OT teaching on a day-to-day basis. But we all have to understand the changes happening, and we cannot deny that. We started with 7 postgraduates in a year training from the department to 13 to 17 to 33 at present. So it is very difficult to keep doing the same way of teaching. So we moved to a more structured way of teaching, which is CBME 7 years back. And we are continuing and very passionate about this. This has come even into our promotions on call basis. We are an active department, as it's mentioned by Dr. Korula, Dr. Nandini Korula, Dr. Rebecca Jacob, and Dr. Grace Korula ma'ams, that we still believe in doing continuous medical educations. We conduct conferences, and this is the glimpse of few which we have done. This happened in 24 regional anesthesia workshop. We also had a couple of days, a week back, the second session of that. Now, these are some pictures from there. Because we have 33 PGs, it's a big responsibility to ensure that they are trained well before they leave department. So every time a batch comes, for last 3 years, we've been organizing basic ultrasound introduction workshop, because ultrasound is nothing but eyes of an anesthesiologist. This year, we have moved to more structured orientation program for our PGs. We have conducted simulation workshop last year. Our own faculty came, and we are going to be conducting another transplant related workshop with CME, which is coming up in May. We do have fellowship courses, one of regional anesthesia, nerve block and pain management, cardiothoracic anesthesia, pediatric anesthesia, advanced clinical work anesthesia fellowship. We do continue the World Federation of Society of Anesthesiologists Pediatric Anesthesia course. And last year, we had 21st student who has got experience from us. We are very passionate about when it comes to training for technicians, because there's one group which really helps us directly. And we do conduct teaching classes for them in our new classroom. Spreading knowledge is our motto, and we not only are thinking about our own PGs, but we think anesthesia has to play a role in teaching MBBS students. And we drafted and curated this beautiful course, which is basic airway and life support. And we gave them these batches, and they were really, really happy with this experience. They showed their happiness by giving us mementos. And have a look at what happened on that day. So apart from this, cardiac advanced resuscitation education under the leadership of Unit 4 happened last year. We've been running AHA-ACLS course organized by Department of Anesthesia since 2020. And last year, we had 5 such courses for the institution. From education, I moved to research. We still have to work hard when it comes to research. We had last year publications, which are 29 publications, and we have currently in the department 54 projects running. We have represented at different conferences. We had 68 national faculty going, international faculty 3. We had presented posters and papers 35, and we won 12 prizes last year. These are some glimpses. Now, coming to services, which is the thing we are very passionate about, and we want to do it, and we do it very safely. And as per annual report, around 40,000 cases we did last year safely, with our morbidity mortality being quite low. We have decent manpower. I will not say we are very strong with the manpower, but we are not bad. I can say that. These are the areas unit-wise we cover. And we are expanding ourselves. We are trying to expand to mission hospitals. Last 2 years, 200 patients have benefited from our colleagues who have gone and served in different mission hospitals. Achievements of department in current time, I think this is as per me. We have created an outreach activity, which is hot fables for schools and training them for life saving activities and first aid. We also in 2019 managed to get ASHA grant, and with the help of which we have got high fidelity sim mom and sim baby in the department. Now, we are not only ESR, we are a little beyond that. We are very socially aware group, and we celebrate each and every event which comes around. And pain, because we passionately believe that pain post-op is one of the reasons why patients don't do so well. So we celebrated last year pain awareness program in the department with the help of, in collaboration with the nursing department. We are a fun group, and we celebrate sports activity actually annually. And we are quite serious about our sports activity. We have 4 groups, and we have permanently divided ourselves in 4 groups, and we really bother and care how much points we get. So this is some highlights from there. We are fun, but we are serious. We have lots of trophies to our credit when it comes to institutional activities and sports in there. This is some fun time. We organize once a month breakfast session where we just come in sunlight, have good food, and enjoy together with smiles. This technician group having retreat, and this is freshers and farewell we celebrate. So I would end saying that you see the smiles here, they are the future. And the past, I can see the present and the future. We totally believe in not to be ministered, but unto but to minister. And with this, I'll end my talk. Thank you so much.
Thank you. With this, we'll end our time here. We thank you for everyone who came and shared this time with us, and all the colleagues and friends. And we are grateful for all our seniors who have come, and for all the seniors who are probably seeing this thing online. And we thank you for your vast contribution and the things that you've done, for the way you molded us, and hope we will pass on and will mold the next generation that's just joined. Thank you once again. Have a pleasant day.